training, research and innovative practices.
Right, a very good morning, good afternoon, and good evening, ladies and gentlemen. I'm Vikas Khanduja, consultant orthopedic surgeon in Cambridge, UK, and one of the founder members of SICOT Pioneer. And it's indeed a pleasure to welcome all of you logging into this webinar from all around the world. Now, in the COVID world of non-contact domains, we've certainly embraced digital competitiveness with the launch of the SICOT Pioneer platform. And through this platform, we've done over 35 events, and we've had over 60,000 views from 110 countries around the world. So big thank you for joining us, and please do continue to follow us. Now, today's webinar is in collaboration with our ever-growing research academy, and a big thank you to Professor Bhandari from Canada and Mr. AJAY MALVIYA from Northumbria for actually taking this on. And this is the first of the four in terms of a series of webinars that we're going to put together on research. And this will culminate finally in the Malaysia meeting where we'll have a full day on research. So big thank you for joining us and actually making this happen. We've also got stellar faculty who've given up their precious time for this webinar, and I'll let AJ and Mo actually introduce them in a minute. We'll try and make this webinar as interactive as possible, so please do post in your questions. And if you can't join us today, you can access them on our on-demand platform as well. Once again, a big thank you for joining us, and hope you enjoy the series and this webinar as well. Over to you, AJ and Mo. Thank you.
Yeah, there you go. Right. Many thanks, Vikas, for the kind introduction, and many thanks, Pioneer, for actually helping us organize this. So welcome, everyone. And the Research Education Committee was tasked to basically promote research education in the SICOT membership. And we've tried to put together a series of webinars culminating in a research symposium in due course. And this is, of course, the first of these. And okay, good. And so this is the team for today. So a warm welcome to Professor Mohit Bhandari, who actually probably needs no introduction. He is one of the most esteemed researchers world across in TNO. And we are proud to have him as the chair of our research academy. He's published more than 1,000 papers, has had almost £100 million worth of grants for various research, and he is one of the dons of TNO, and I'm sure we are going to learn a lot from him and obviously all the other speakers. And a warm welcome to Prof Raj Shakaran and Prof Adamson from UK, who I will introduce in due course. So this is the team. Without a good team, it's impossible to put together something like this. And these are the members who worked really hard to put the webinars together. Naritan from Albania, Tom Hilton from South Africa, Aju Basko from India, and Sashi from Oman, and Steve Chung from Hong Kong. So my thanks to all of these people who worked really hard over time. And so this is the research education roadmap. 4 sets of webinars culminating in a research symposium in Kuala Lumpur. And I'm certainly looking forward to all of these, and I'm sure it will be a great learning experience for us. So these are the talks for today, and I'll like to hand over the mic to Professor Bhandari. He is going to give us a brief intro of the vision of the Research Academy, and then proceed with his talk. So many thanks again.
Great. Thanks, Ajay. I'm just going to share my screen if I can here quickly. And what I'll do is also, while I'm doing this, Just take a moment, if I could, also to thank our, SICOT pioneers, certainly all your hard work, and as importantly, thanking each and every one of our guest lecturers today. I think it'll be a wonderful session. I'm here primarily to share with you, a very fundamental question, why research matters. And when we think about it, we have to be thinking about ultimately not so much an evolution, but a revolution. And the reason I say revolution, and I think we need to be thinking of it this way, is that in SICOT, we have so many member countries. We have an overarching objective that ultimately we want to engage you as surgeons and scientists. We want to find resources to support you. We want to find ways to reward your scholarly activity. And ultimately, we want collaboration. And we will get collaboration through what I believe can be almost a research revolt. As a proud member of SICOT and taking a role as a Research Academy chair, I get the wonderful opportunity to interact within the context of research within SICOT. And I encourage you all to be thinking about, research questions that are important for research grants. I encourage you to attend meetings and be as active as you can, both online as well as in person. We hope, again, in Kuala Lumpur that we'll be once again returning to face-to-face meetings in a robust way. And ultimately, as we are today, really promoting research education with AJAY, who serves both in the mentorship role, but also a research education role. But why are we here? You are listening because you believe that signal matters. If the last 2 years has taught us anything, it's taught us that there's lots and lots of noise. And in fact, data becomes critical in situations in which there are perceived needs for best evidence. So why don't we begin with a revolt? And remember again, friends, it begins with you. Evidence becomes your storytelling tool, and they who own the evidence can tell their stories. The best ideas aren't always the most complex ones. The best ideas are often very simple, and by becoming simple, many more people can engage around the world, and therefore they become big. Our world is much smaller than we think. And within SICOT, I think we should be doing and can be doing more to collaborate with respect to our research ideas and our research questions. Today you are here, I presume, because you are a lifelong learner. Whether you are beginning your career or whether you are a senior scientist or surgeon, research is lifelong learning, and that's what it teaches us. And thank you for joining us today, because ultimately, we can continue to push things off until tomorrow, but that does not matter. But let's go back. Why research? 1990, EBM, evidence-based medicine, was basically designated an attitude of enlightened skepticism. Pioneers in evidence-based medicine in various areas had said, you need a real passion for research, a passion based on curiosity rather than becoming famous. David Sackett, largely considered the forefather of randomized trials, one of them anyways, it's an overwhelming desire to address serious questions and problems. And there is a thrill. There's a thrill of discoveries. It's a high. All of these things bring us together into this milieu that we call the hierarchy of evidence. And ultimately, an area in which we look at all different study designs as being important and appropriate. There is no one perfect design. But there is many, many opportunities to ask questions depending on the type of question you have. Remember, if you own the evidence, you own the story. So let me ask you again, why research? Why are you thinking about this? Well, for me, there are two really major aspects of any clinical practice. One is your general degree of skill, which you learn through training and execution and practice and deliberate practice. And then there is decision-making. I think for most of us, after you've achieved a degree of competence and excellence in an area, sound clinical judgment is absolutely essential to ensure the highest standards of patient safety and care. What does that mean? It means we need to make better decisions, and data and evidence helps us make better decisions. Remember this, poor decisions perfectly executed always result in poor outcomes. Let me say that again. Poor decisions perfectly executed, will always result in poor outcomes. So as good as your technique may be, if you consistently make poor decisions, your outcomes cannot be good. Evidence helps us. The power of expertise is the integration of our surgical expertise with the best available research evidence. You can be a consumer of evidence, or you can be a producer, but ultimately research is very important. I also put out to say that it's been almost a decade since our last edition, and the new edition of Evidence-Based Orthopaedics has just come out. And more so just to tell you that orthopedics has lots and lots of evidence. But here's the point. We have lots more to do. And the world can contribute much, much more. So when you think about evidence, think about, what's your role in helping this? And the reason I think it's important for us, specifically at SICOT, to be considering collaborating more is because small studies actually have very big risk. In fact, some of the biggest challenges with research is that we cannot always believe very small studies. So when we collaborate, we can use our collective patient experiences. And when we go back and look at studies in which we had only recruited 50 patients, and then we see what happens over time, when we recruit many, many more patients, over 1,000 patients, we see that the results can completely change. Anything from suggesting that the unreamed tibial nail is favored all the way through to demonstrating, in fact, that the reamed nail is better. And what typically happens is you need more patients to get a better idea of what the evidence is. Another small study of 100 patients. Now, keep in mind, friends, in a recent publication in the Journal of Bone and Joint Surgery, the average sample size for research studies was about 80 patients. Think about this, 80 patients. So we're expected to change practice when 40 patients get some sort of result from one treatment compared to a control. And the reason is most people ignore these sorts of studies because they just don't believe them. And here we go again, a study of our pilot suggested one thing, and then our larger study of 1,500 patients, in fact, suggested quite the opposite. And what is this issue? And simply put, it's called fragility. What it means is that we just don't have enough patients and therefore enough patient outcomes to be able to definitively say that one treatment is better than another when we have small sample sizes. So here's an example where there's a total of 41 different reoperations that were part of the study that suggested that using a biologic for open fractures was better. But imagine this, that was the result. What if we just repeated that study? And this time we had 15 versus 26 events, right? 15 reoperations in the treatment group and 26 in the control group versus the original paper. What happens is the study becomes completely flipped. It goes from a significant study to a non-significant study. All this means is more patients helps us reduce the fragility. And look what happened in this study. They repeated the study in March 2011, and they found no difference. This isn't just an orthopedic problem, friends. This is happening all over surgery. When we see these small studies, in this particular case, just over 50 patients or so, and you see, in fact, look, they say, major reductions in risk with our treatment, but they only have 15 different outcome events. Well, it takes all but a single outcome event to flip from one side to the other if that study was repeated, and you have a negative study. This is the challenge with these small studies under 100 patients. It takes a globe to answer a research question, and that is why SICOT Pioneer and our work together is just begun. Recognize this city? Well, our cities are looking closer and closer. The top is Los Angeles, the bottom is Japan. Wherever you are around the world, we are actually more alike than we are different. And the point I make here is that research that matters is significant for everybody. Research that matters, it creates a global connectivity. Research that matters grows our team, and ultimately research that matter contributes to the well-being of all people. So we need more countries, more centers, more surgeons, more scientists, and more patients. And big ideas, as I said, are by necessity simple ones. They solve fundamental problems. And remember, the road to big is filled with great intentions. But people will tell you along the way, oh, you can't do this. But it's not because you can't do it, it's because they feel they can't do it. but you have to respond to them and say, we can do this together. Research is failure. We have to be confident and accepting that our hypothesis may not always be true. That's okay. If we're going to ask big questions, we have to be prepared to fail. And every trial I've conducted, truthfully, has succeeded despite a series of near fatal failures. At the end of it, the root cause of failure is that we go too complex too quickly. We don't engage ourselves to learn, to gain the expertise, and to work with people with that expertise. We build infrastructure, or we work with associations that have infrastructure. And ultimately, we have to have grit, creativity, and conviction. Let me leave you with one final thought, though. At the end of the day, our main job is to invest. Our main job is to develop talent. This is the beginning of a series in which we hope that we will develop many of you, and hopefully spark some of you to have a brighter shining light when you think about the opportunities for why research. So friends, it's never too late for a revolution. Remember, it begins with you. Evidence is your storytelling tool. Very simple ideas are big ones. Our world is much smaller than we think, so let's begin collaborating. Lifelong learning is exactly what research teaches us, and that is why we do research. Let's start today. Let's not wait until tomorrow. I'm so generally excited to be part of a symposium in which we get a chance to hear from two other spectacular speakers who I know will educate us, and I'll certainly be taking notes. Thank you all.
Many thanks. That was brilliant. Very inspiring. So there is going to be a series of questions for a poll that we are also conducting. So I would suggest that we answer them. And Sofian, would you run at least a couple of questions now? Or do you want to wait?
To get more answers.
Sure. Yeah. Thank you. Or do you want us to proceed to the next presentation? Okay, so we will just carry on. The next speaker is Prof Raj Shakaran, who again actually needs probably no introduction. Most of us would probably know about him. He is one of the well-renowned names from India. He has been the president of SICOT. He's been the president of Indian Orthopaedic Association. He's currently the president of the Asia Pacific Spine Society. He is the chair of the Ganga Hospital in TNO and Spine. One of the brilliant things he's done is the Ganga scoring system, which is probably the most applicable scoring system for open fractures. And he is going to talk to us about research in the developing world and how we can contribute from that angle. And he's recently given a TED talk on this as well, and I would encourage you to actually go on YouTube and watch it. So Prof Raj Shakaran.
Thank you, Ajay. Thank you, Vikas, Gau, and Mohit for this opportunity. It's always a pleasure to be reconnected to SICOT, and especially for research. And Mohit gave a brilliant talk, as always, on why research is necessary. I would just carry it a little forward on why it should actually be developing countries that should do more research. Now, when we started the Research Academy about 7 years ago, the idea was that all the members of SICOT were surgeons, and we wanted to take away the dichotomy where the surgeon and the researcher are becoming two different entities, and we wanted to make surgeon as a scientist. But however, if you look at the reality, you will find still that 95% of research comes from the top 10 countries. And that brings us to question why developing nations are not doing research, and also why they should be doing their own research. Now, we all think that we are all living in the same planet, the globe, what we call as the planet Earth. But if you look deeply, we are actually living in two completely different planets, the developed world and the developing world. And if you ask what is the difference, it's huge. Because if you see, some of the countries have got a per capita income of $126,000 compared to some which have got just $266,000. And when you're looking at so much discrepancy and lack of wealth and poverty, many things are actually lost. And you may think that it is luxury that is lost, but we don't realize that one of the most important things that is lost is the lost opportunity for innovations and research. And because of that, what happens is that solutions for problems in one part of the world are often sought from research from another part of the world. And here comes the major problem. If you look at these four people, the one at the top and the ones at the bottom, and if you ask what is the difference between them, it is one single word: everything. Now, when they get a disease, and when we look at what's happening, the difference is in everything: the disease that they get, the treatment that is available for them, the infrastructure that is available, the cost provided and the money available, affordability, and even the expectations that they have out of the treatment is completely different. So when everything else is different, it is wrong to think that the solution can be the same. Solutions are either not available or not affordable when they come from a different part of the world. Now let's just take, this morning we had a major symposium, and I was just looking at what is the topic that interests. And it is just, we are talking about 2 millimeter subsidence or 10 degrees of radiological kyphosis. And this is what is the matter that is occupying a large part of discussion. And we really need that. What research we now need is not just on treatment, not just on radiological parameters or outcome, but we need research on prevention. So when the solution comes from a developed world, it naturally comes with the costs, the business plans and profits of the developed world. And the solution naturally becomes expensive. It escalates the costs to the needy, often making it unaffordable and profit in the business world. So this cannot be a solution, because a solution is not a solution if it is not available or affordable. So what is the solution? Self-innovation is actually the key. But we know from many success stories that the story can be otherwise. And I would like to tell you about the story of Oro Lab, a lab which was designed and created by Aravind Hospitals, the biggest ophthalmological institute in South India. In the early 90s, India was the home to the largest number of cataract blind. And cataract surgery without an intraocular lens was the norm. And the reason was very simple. It was the prohibitive price of the intraocular lens, which was costing in excess of $100 per intraocular lens. And because India was not considered a viable market for IOL, there was no concentration on this. And in scenario in Aravind was that Aravind's financial resources did not allow implanting a lens which cost $100. And that means that they had to operate on these patients. A surgery which was different, an outcome that was different was being given to their patients from what was given in the developed world. And Dr. Venkateswamy thought that IOL had the potential to give a new lease of life to thousands of patients, and he decided that they have to do a research and they have to set up a facility and to manufacture it locally. So what followed was tremendous. They produced the IOL of equal quality at the cost of $2 per lens. And it was cheaper to when they supplied it to other NGOs. So market followed with the similar pricing. And today the entire industry is delivering products at a low cost and acceptable quality because of their research. Research also leads to empowerment and capacity building. And that is exactly what is appearing more important to me, because it avoids knowledge dependence, which is worse than economic dependence in this modern scientific world. Now, Aerolab, now today, if you look at it, it supplies more than 160 countries worldwide, and it has got a huge amount. From just starting at 150 lenses per day, they now produce 12,000 lenses per day. And they are the reason why multiple millions of people around the world are having a better research. Now, if you take this example, and then we are convinced that we need to be self-sufficient, we need to do our own research, we need to build our own infrastructure, then why then research is not performed in developed countries? And I would say that it is because of the thought process that research needs a large infrastructure as it is done in the West, and it often needs a lot of funds, a lot of trained personnel and expertise, which are scarce in the developing world. But it is largely true to a great extent. But I would also like to emphasize that in many aspects of medical research, an inquisitive mind, observations, perfect data documentation, and analysis can be sufficient. Mohit actually said a very nice thing in one of his slides. He said, a good idea, a simple idea which just questions a practicing process and brings about an innovation is one of the best things that can happen. I would like to talk about our own research as an example. And you know that tuberculosis is as old as man himself, but these kinds of horrendous deformities were there all the time. Even though the drugs were good enough to completely cure the disease, 15% of the population with tuberculosis of the spine were left. And we had to just look at, observe, carefully document, and look at what was leading to a deformity, led us to actually devise these predictive radiological signs. These signs do not even need a CT scan or an MRI. It's from plain radiographs which are available in every part of the world where spinal tuberculosis is in. And we were able to make sure that just looking at the signs, it was able to predict which child required surgery so that such prevention is not there. Now, TB spine still gives rise to a huge amount of possibility of clinical research even today. Even today in the world, there is no consensus on how much of anti-tuberculosis, what is the duration you require. Is it 6 months, 9 months, 12 months, 18 months? And there are institutes in this world which are still now giving 24 months. So these are actually fertile areas where clinical research can be done. Taking up the process of even open injuries, which is a big problem of the developing world. There are so many aspects by which you can do. And just the top question, when you see a patient in front of you, the question of whether you have to salvage or whether you have to decide on amputation was a major problem. Because all the available scores were for injuries with a vascular injury. And that is why we thought that we should bring up a score specifically for type 3B injuries, which is now widely followed around the world. It did not take us money, it did not require infrastructure, it did not require a big research setup, but it just required careful documentation, follow-up, and an analysis. With this, we were able to change many practices. When we were doing this in 1992, closure of an open injury like this was a taboo. I mean, people would look up at askance if you say that you're going to close a wound. And when we presented the first study of this in the American Academy, there was a heated discussion. But we were able to prove that this is possible. And this changed the practice across the world and also took away the need for expensive flaps and where a lot of expertise is also required. And you know, by just combining orthopedics and plastic surgery, devise a procedure by which these people can get back to normal. So what I mean is research need not be only at molecular level. It need not be just at genetic or just looking at very expensive things. Good observation, documentation, inquisitive mind, and good data analysis is required. There is another important reason why developing countries should seek their own solutions. Because there is always a question of genuinity when the results come from elsewhere. This is now very well established. What results you get in research many times depends on who funds the research. And if you look at the current status of clinical trials, you will find that only 8 of the 200 major clinical trials that are conducted are independent of industry sponsors. And you can see the trial sponsors were responsible for data analysis in 73% of the trials. Now, that is actually the reason why there are big fiascos. And we can tell the story of steroids in spinal cord injuries, where you have found that these were not published just in ordinary journals. It is in the JAMA, it is in the New England Journal of Medicine, and it is in all the top journals. But what actually happens is when it is funded by an industry, then you find that everything falls flat. Now, if you look at the back pain and disc research, 16 types of interventions with extremely good findings and outcomes documented have been published. And at the end, you find after 2 years, 3 years of practice, when they come into the practice, you find that none of them are outcome is no better than conservative treatment. Why? Because there is another motive, and it always is a problem, that the genuinity of all research findings when industry sponsor needs validation, even when published in famous journals. So I think we in the developing world have to look at what Sarmiento said. We have to be less attracted for the latest, costliest, and most interventional, which is actually the focus of research in a large part of the developed world. And we need to be careful that we have an appropriate solution for us. So if we are from a developing world, what I mean is that 80% of us are from the developing world. There is so much you can do for the welfare of humanity through research. Molecular research, high funder, high budget research is not the only research. They are more often chasing new expensive remedies for old diseases. We have to change from a surgeon to the surgeon scientist, because developing countries have greater than 60% of the world population and greater than 75% of the disease burden. And when you import a solution from outside, it often is not affordable, it is not often appropriate. How is this topic relevant to research and to SICOT? So when I got the invitation from Vikas, I was just thinking that I should talk on this because this is something very highly relevant to SICOT. Now, we are from 127 countries, surgeon members from every corner of the world. There is no disease, no orthopedic problem for which an appropriate solution cannot be found. For example, just take one simple aspect. Bacterial flora and antibiotic resistance in post-operative infections around the world. Now, we all go by the textbook description that Staphylococcus aureus is the most common cause, and so cefuroxime or cephalosporin is the best preoperative antibiotic. Is it really true? Do we really know? I know for sure in many parts of the world, especially in Asia, gram-negative organisms are more common in the post-operative infections. But where is the problem? Why can't we change our practice? Because there is no documentation, there is no publication. So why will not it be possible for SICOT to conduct a worldwide research? This is going to be very simple, less expensive, where every surgeon just documents whenever there is a post-operative infection, what is the flora and what was the antibiotic resistance and sensitivity pattern. And that would completely change the way in which we are looking, and also the practice pathways and the choice of preoperative antibiotics. So this is something that we all need to get convinced that since we are having the bulk of the disease burden, why not be it us that finds the research solutions? So thank you, Ajay, thank you, Mohit, Gaw, and Vikas for this opportunity. Thank you very much.
Thanks a lot, Raja. This was brilliant. I mean, very pertinent points. And I think your message is very similar to what Prof Bhandari was also saying. Simplicity, the question that needs to be asked should be simple. Yeah. So next on is Prof Joy Adamson, who is based in UK. And she is a research methodologist who works in applied health research in the University of York. And she's also got affiliation with the Newcastle University. She has extensive research experience. She is well qualified in dealing with qualitative and quantitative research, but her the main focus lately has been on qualitative research. Now, qualitative research as a topic in orthopedic perhaps is actually not that old. At least I was introduced to it only around 5-6 years ago. Before that, I think probably orthopedic trials could be blamed to be not concentrating on qualitative aspect at all. But what is qualitative research? Prof Adamson will enlighten us. Thank you.
Hello, everybody. Yes, I'm really thrilled to be here today, and I'm very pleased to be asked. It's nice to be part of what is a really ambitious and important organisation. So I'm thrilled to be talking to you today, in particular about qualitative research methods. So as AJAY has said, I'm based at York Trials Unit at the University of York in the UK, and I currently hold one of the Royal College of Surgery chairs in surgical trials and health research. So as well as doing trials, I also work on qualitative methods, a lot of the time alongside RCTs, and that's the kind of topic I'm going to talk to you about today. So because of the two previous talks, we're obviously all familiar with randomized control trials, which are known to be the gold standard of research and evidence-based practice in terms of effectiveness and cost-effectiveness. But many of the questions that we wish to answer within orthopaedic surgery and trauma research are outside of what constitutes the best treatment. Rather, they pertain to, for example, how can we best develop care pathways, both pre and post-surgery, what factors are important to patients, including identifying the most appropriate outcomes following treatments. We want to know how patients experience treatments and are they acceptable, as well as questions like how can research evidence be optimally implemented into clinical care. For those of you who are not familiar with qualitative methods, they have a long history, in particular within social research, to help us to gain an understanding of concepts, opinions, and experiences. Many of the research questions we have are best addressed through the use of qualitative methods, but often little is known or understood about these techniques, especially when compared to trials or epidemiological research. So here I've tried to draw up a very simplistic comparison between epidemiological studies and qualitative studies, so we can see how these types of approaches differ across all aspects of the study design, including the purpose. So with RCTs, we know that often we're trying to test a hypothesis of treatment A versus treatment B, whereas within qualitative methods, what we're trying to do is understand and interpret the social aspects of healthcare practices. But as well as the purpose of the studies, qualitative research differs from quantitative techniques in terms of the sample sizes, the outcome measurements, the data collection techniques we use, and our approach to analysis of the data. So now I'm going to mention each one of these in turn in just a little bit more detail. In qualitative research, we're often seeking to collect detailed and in-depth information about a particular topic. This is most often in the form of interviews, focus groups, and/or observations, although sometimes this can expand out into pictures or documents. Data is mostly in the form of words. This is often the case of being transcriptions of interviews rather than numerical data. So it's a very different approach to answer very different types of research questions. Which is in contrast to what Mohit was talking about in terms of low numbers, because qualitative research is interested in in-depth understanding of experiences and social interactions. These methods are necessarily associated with relatively small sample sizes, whereby research participants are selected specifically because they have particular attributes or characteristics, which is known as purpose of sampling, rather than the more large and often random samples that are associated with quantitative studies. So typically a qualitative study will include around 15 to 40 participants, and that's normal for this type of research. Because data is most often in the form of words, and as I said, often can be transcripts of interviews or conversations you have with your research participants, data are therefore not analysed statistically, rather they're analysed thematically, whereby initially sections of text are given labels to describe what that piece of text is about, and this is called coding. Then the researcher draws out common themes from across the data set and presents the findings in a narrative way. So what can qualitative research be used for? It can be used to explore a new area of research to find out what the main concepts are. It can be used to identify key issues from across different stakeholder groups, and that can be patients themselves or different types of clinicians. It can help us to understand current practice and how that's operationalized. It can help us to explain unanticipated or contradictory findings, or it can be used simply to illuminate a particular research topic. However, I think these aspects are best demonstrated through a couple of illustrative examples, which I'm drawing on from orthopaedic surgery and trauma research. So my first example, given that I know you're all familiar with randomized control trials, I thought it would be helpful to draw on the use of qualitative methods alongside RCTs as the first example of how these techniques are currently being used in research practice. It's increasingly common to see qualitative data collection, normally interviews, used alongside RCTs for a number of purposes. For example, to help develop an appropriate complex intervention, to explore the acceptability of treatments on offer in a trial. Qualitative methods can be used alongside quantitative methods to explore the fidelity of an intervention, and such information can be used to help us understand trial findings. In addition, in the example I'm going to use here, qualitative methods are being used for trial recruitment optimization. We know from what Mo has said that it's really important to get the correct number of individuals into trials for their findings to be meaningful. So what can we learn from recruiting clinicians and or patients about how they feel about trial participation, and how can this help us to optimize recruitment? This is a recent paper from my team in York, which has been published in the journal Trials. This paper was based on data collected from across 2 orthopaedic surgery trials, which we're currently running in the trials unit. One of the trials was on external versus internal frames for pilon fracture, and one was for surgery versus conservative management of stable thoracolumbar fractures. Our aim was to find out how to optimize recruitment into these trials by exploring patients, surgeons, and the views of local recruiting staff and their experiences of the interventions and trial processes. So you'll note, because this was a qualitative study, this was based on interviews with 37 health professionals who were recruiting into these trials and 22 eligible participants. Our findings highlighted the importance of the following factors which influence trial participation. For example, whether the clinician and patients were truly in equipoise at the start of the study, or whether in fact they had a treatment preference. How they understood randomization and whether they thought this concept was acceptable. The importance of trial communication and the importance of patient circumstances. For example, would their work or family lives impact on their ability to participate in the trial or the treatments that were on offer? We found that altruism was an important factor, and also trust in the clinical and research teams. One of the other factors we found to be important was how the eligibility criteria for the trial were being used across the sites. In this case, we were asking, in one of our examples, around stable thoracolumbar fractures, but we found there was a lot of differences between our sites about what actually constituted what was considered stable. And also the importance of the impact of complex patient pathways in trial recruitment. For example, being told by an emergency department clinician that someone with a particular fracture wouldn't need surgery, which then inadvertently influenced their expectations when they were offered participation in the trial. So if we are aware of the complex factors that influence patient and clinician motivations to participate in research, we can adapt our approach to ensure that we minimize the scope for misunderstanding, and we can adopt our trial processes accordingly. The second important area I wanted to highlight is where qualitative research has been particularly important in the vital process of incorporating high-quality research evidence actually into practice. In this study by Gove and colleagues, they aim to explore how guidelines are implemented into clinical practice and to uncover why there is so much variation observed across individuals and sites in terms of the provision of care for the same condition. They did this through the exploration of 3 case sites and included observations of practice, interviews with a range of staff, and analysis of key documents, for example, care plans that were in place and treatment protocols in the different sites. They compared this data within and between case sites. The study identified 17 different sources of knowledge and evidence which influenced clinical decisions in elective orthopaedic surgery. This diagram is taken directly from the paper and demonstrates well the types of influences that are present. Differences in how evidence and knowledge are used across individuals, professional groups, and organisations contribute to the variations in practice, even when clear evidence-based guidelines are available. Whilst clinical guidelines are a fundamental part of practice, there are only one type of evidence that influences clinical decisions, so new approaches to guideline implementation need to appreciate and incorporate this level of complexity. Hopefully, the 2 examples I've provided have given some insight into the ways in which qualitative research can be used in this discipline. We have to put aside what we know about trials and epidemiological research and see this as a different methodological approach which addresses different types of questions. Just before I end, I wanted to alert you to a UK website, which you might not have come across, which is called Health Talk Online, which is based on qualitative interviews with patients and sometimes family members talking about their experiences over a range of conditions. This has a chapter on bone surgery, which may be of interest to some people in the audience. So just to finish, I just wanted to highlight a few key learning points: that qualitative research is a form of social inquiry to gain an in-depth understanding of concepts, opinions, and experiences. In-depth data is collected, not variables and not quantitative measures, through interviewing, focus groups, and observations. And this data is analysed thematically, not statistically. And qualitative research has multiple applications in orthopaedic research, including patient understanding and experience of their conditions and treatments, can be used alongside RCTs to understand trial processes and trial findings, and could also be used to see how clinicians understand research findings and how they implement these into their own evidence-based practice. Thank you.
Thanks, Joe. That was perfect. Exactly what we needed. From what I can understand, one of your messages was that the qualitative research is brilliant for hypothesis generation, to understand what research questions we need to be truly asking. But Prof Bhandari is going to take over. He will run through all of the talks and basically the main conclusions. Thank you.
Great. Thanks so much. I wonder if I could just ask each of you both just one question. Now, we have about just under 10 minutes left. And if I could begin with you, Raja, you give a very appropriately so impassioned plea for surgeons in developing nations to be much more proactive and engage in research, in a much more directly active way. So for someone who's listening, someone who watches this webinar, who hasn't necessarily engaged in the way you'd like them to, how do they start? Like, what are some of the first steps someone can make, to start thinking about doing research in the developing world?
Yeah. So, Mohit, as all of us know, it's everything in the research question. And when the question is something that is appropriate to you and it will influence your practice, then you have interest in the research because you have got a bite into it. So when I look back on our journey into research, the way we actually started was by doing a good audit. So when we do a good audit of all our cases, and then we actually, at the end of 3 months, we find what is the problem that we are facing. And what are the conditions about which we don't have a clear idea or a clear practice pathway, then we took that as a research question and started planning our research. That way, it was not research for research's sake, but it was research that had a direct implication and benefit in our practice. So for this kind of clinical research, it doesn't require much thought process. I mean, it doesn't require a big team. It doesn't require a big infrastructure. I would advise that every surgeon should start from their own clinical practice a good audit. Where you are not doing well should form the first basis of your research.
Thank you. It also got me thinking, Joy, from your presentation, that a real wonderful, I wouldn't say entry, because I think there's a lot more complexity to qualitative research than many of us often realize when we get started. But it would seem to me that it would be an extremely powerful tool, as you suggested, and certainly an opportunity for us to gain more insight. And I think also about all the diversity of membership at SICOT. But one thing I did want to ask you, a direct pointed issue, is you raised very appropriately so the misperceptions that we need. Sample size is often the limiting factor. Often most journals and agencies who aren't familiar with qualitative research in orthopedics misunderstand that a qualitative study of 10 patients is somehow not meaningful. How do you respond to those sorts of reviewers, or how do we begin, Joy, to educate our orthopedic community, just as you are doing, in a broader way?
Oh, I mean, I wish I had some money for each time I've had that feedback from a journal, because I think it is just the fact that qualitative research is still largely misunderstood a lot around some communities. So I completely agree with what you say. When you're in a trial context, obviously you want those large numbers, but I think it's just about it's about having to park those, it's almost like you have to park everything you've learned already about research methods, because we know in epidemiological studies and in RCTs, we need the larger sample sizes to have sufficient power. And here, I guess it's just about, I suppose, as much as possible, putting out that education, making sure people are familiar with qualitative research, to say, actually, in this case, it really isn't so much about the numbers. And we have, techniques to try and say, well, actually, we may only have spoken to 15 people, but actually look at all this information that we found out at this point. And it's because it's pertinent to the type of question that we're answering. We're not trying to answer it statistically or with the use of variables. It's about talking to people and getting that in-depth understanding. Yeah.
Well, the truth of it is, I think for those listening in and those who will watch this, there isn't a single one of us that hasn't, responded to a survey, and checked off boxes. But then you get into the room and you talk to someone, and it's all the other nuanced discussions that happen. We realize that our life and responses aren't just a checkbox, and having much more detailed opportunities besides just data point collection can add a ton of new insights. I wonder, Raja and Ajay, from your experience, have you had experience with focus group work, and from your own experiences, what's been some of the pearls for you in terms of really engaging and having meaningful discussions with patients and or surgeons around issues?
So if I can come in first, I think Mohit, meaningful discussions with the patients is everything. I am not a great believer in questionnaires, and I'm a strong disbeliever in telephone conversations and getting the questionnaires done. Now, if you just look at one simple factor of SF36 and the time that if we do a proper spine work and research, they need SF36 to be done, then ODI and something else, pain scale. That's a 45 minutes engagement with the patient. And when the patient knows that it is not for his or her benefit, but it is just actually for a research of the unit or the thing, they are really not so interested in answering, and they want to get it over with as fast as possible, and they would just tick whatever comes to my mind. I have many times asked the patients, why did you tick this? They will look at it and say, oh, sorry, I didn't mean it actually, and they would actually change. And when this actually happens right in front of your eyes, I have very little belief in telephonic SF36. So I completely agree with Joy. It doesn't matter on big numbers. It actually, small numbers, focused group, focused discussion, focused questions, focused answers, to me, far outweighs than big numbers. And that's one of the reasons I also want to ask you one question, Mohit. I know you are a great advocate of large numbers and big data. For me, there is one problem with that, in that, when you get into big data and multiple institutions around multiple countries, different parts of the world, how do you check the authenticity of this data? Because that is going to actually determine what comes out of your research. We have a trouble when we even enroll 5 or 6 centers to get all the data accurately. How do you do that in 500 countries, 500 institutions?
Yeah, and I would tell you that, you and I can have a discussion for hours. I'm sure Joy has lots of thoughts on this as well. But I would say to you that the preface that collaboration, can be powerful is also under the preference that we are collecting data accurately, honestly, and transparently. So without that, Roger, you're 100% correct. Bad data, lots of bad data doesn't make good data come out of it, right? And so we 100% agree. But there are lots and lots of challenges. But it also, I think, as you said, Jess, it begins with the institution and the surgeon and scientists who are leading that institution to help us in that regard, right? So research isn't for everybody, but those who engage take on that ethical responsibility to participate and do the best we all can. So no one's perfect, but we do try our best. But I appreciate your point. Point well taken. Listen, we are just a minute over, and I want to be very respectful of everyone's time. Ajay, you might have a slide or two, but I'm happy to give a few concluding statements. But we would love for everyone here to fill out the post-webinar survey, and then you'll be able to, at this point, also be able to get a personalized certificate of attendance. You can see here just by getting your phone on this. I presume, Ajay, they just get their phone against this, and they should be able to get the survey from this?
That's right, yeah.
Okay, that's great. Ajay, did you have any concluding comments? And then I'll finish off.
No, you just carry on, Mohit.
Okay.
So I think you've got some points, isn't it?
Okay. Well, listen, I can't thank you all enough. And if I could, just on behalf of SICOT, Ajay, myself, Gow, and Vikas, thank both Profs Rajasekaran and Abramson for enlightening us, spending a bit of their morning with us, or their afternoons with us, I should say, depending on what time of the world it is for you. And let me just end with an acronym. I started with REVOLT, and I was making notes, and I used the word START, START, as a way for all of us to think. This is the beginning series of lectures, but more importantly, this is, for some of you, the start of hopefully an exciting interest in research. S, surgeons must get involved. They must lead. We heard that today from Professor Rajasekaran, and collaborate with scientists. I think we heard that also from Joy Adamson. So, I mean, I think we have to work together in this. Translating research ultimately requires us, if we want to be truly generalizable, to have all of our nations participating, not just developed nations, but our developing nations. So we need surgeons and scientists working together, as I think you've heard both from Joy and Raja today. All forms of research matter. You heard anything from the randomized trial, which is often powered by large numbers of patients, to qualitative designs, which actually gets its power from in-depth conversations of few patients usually. You don't need too many to get these insights. And so I think that's an important message that we all want to make sure you get. Our revolution is what is needed, not an evolution, especially now when we have to be looking at disruptive ways to work together and disruptive ways in which we can actually find meaningful answers to help physicians and surgeons make better decisions for their patients. And last and not least, start begins with an S and ends with a T. Today, friends, start today. So I urge you all to take advantage. And I thank all of our speakers and SICOT once again. Have a wonderful rest of your day. Thank you so much.
Thank you very much. Wise words. Brilliant. Thank you.
Thank you. Bye-bye.
Bye-bye.
Thanks, everyone.